Good evening. My name is Lauren Lele, and I am the Director of Community Benefits at Newton-Wellesley Hospital. Thank you for joining us for this two-part series titled Heartburn and Reflux, What You Need to Know About GERD, hosted by the Heartburn and Reflux program at Newton-Wellesley. Tonight's program is focused specifically on heartburn and how to prevent it with diet and lifestyle changes. As a reminder, the second program in the series will be held on November 23rd and will be on medical and surgical treatments for heartburn and reflux. Before the program officially starts, I would like to mention a few of the logistics for the next hour and a half. We will be leaving plenty of time for questions and answers, and would ask that you use the question and answer feature at the bottom of the screen to type your questions in. However, if you're more comfortable using the chat, that is fine too. I will monitor these questions and be asking them of our speakers at the end of the presentation portion of the program. And now let me tell you a bit about who you will be hearing from tonight. Alexandra Maltby is a physician's assistant in the Heartburn and Reflux program and in the Department of General Surgery at Newton-Wellesley Hospital. She received her master's degree in physician assistant studies from Bay Path University, and she has been with Newton-Wellesley and Mass General Hospital since 2017. Sarah Andres is a registered dietitian in the Department of Surgery. She specializes in gastrointestinal disorders, including GERD. She received her master's degree in nutrition from Tufts University and her clinical dietetics training from the National Institutes of Health. She has been with Newton-Wellesley since 2019. And now to begin our program, I will turn it over to Alexandra and Sarah.
Thank you, Lauren. All right, I'm going to share my screen. Okay. Great. So thank you so much for that introduction. So yes, my name's Alex. I'm going to be starting off our talk today. And this week, we're going to be focusing on diagnosing and preventing heartburn. So to start, what is heartburn or acid reflux? Well, heartburn and acid reflux are actually two symptoms of a disease process called GERD, which is gastroesophageal reflux disease, GERD. And simply put, it's when stomach contents, which tend to be acidic, reflux up into the esophagus and cause pretty bothersome symptoms. So other than heartburn and reflux, there can be a lot of other symptoms of GERD, such as a sour or acidic taste in the mouth, non-cardiac chest pain. Some patients have nausea, a sore throat, voice hoarseness, or a raspy voice is common as well. So is trouble swallowing or feeling like food is getting stuck in the chest. Sometimes patients will have pain with swallowing as well. Patients can have cough as well as frequent throat clearing, and then globus sensation, which is kind of the sensation that something is stuck in the back of the throat when you swallow, but there's nothing actually there. So how common is GERD? It's pretty common. About 20% of adults in the US suffer from GERD, and that's about 21 million people. We know that about half of all adults at one point or another will complain of heartburn at some point in their life. And the incidence of GERD actually increases significantly after age 40. We know that 40% of people report that they have symptoms on an intermittent basis, and about 10 to 20% report symptoms weekly. So all of that to say that it's a very common disease process. And while the medications that we use to treat GERD are not particularly expensive, the overall cost and kind of burden on our healthcare system for patients with GERD is about double that for patients without GERD. So it's a significant burden to our healthcare system. All right, let's talk about some of the risk factors for GERD. We already mentioned one of them, which is older age. So as you get older, unfortunately, the likelihood that you're going to develop GERD increases, as with most other things, right? Higher body mass index. So especially our BMI, which is Patients that carry their weight in their abdomen, especially, we know that this is going to put a lot of pressure on that lower esophageal valve. And I'll get to that in a little bit about why that's important, but that's definitely a risk factor for GERD. Smoking is a huge risk factor. Smoking decreases salivation in the mouth. It can lead to irritation and inflammation of the esophagus, and it can cause relaxation of that lower esophageal valve. So big risk factor. It's also a risk factor for Barrett's esophagus, which we will talk about later on, and esophageal cancer. Anxiety, depression, a sedentary lifestyle, and eating habits also are risk factors for GERD. Okay, what causes GERD? So I'm going to get into a little bit of an anatomy and physiology lesson. So taking you back to high school, maybe college. So bear with me a little bit, but I think that it's really important to have an understanding of why diseases occur in the body, because then we can understand how we can treat them better. So I'm going to talk about 4 separate things. And the first is this valve that I keep referring to. So if you look at the photo here, I don't know if you can see my cursor, but the photo on the left, it's obviously a cartoon, but it's of normal anatomy. So this is the esophagus here, and then this is the stomach. And in between the esophagus and the stomach, there's a valve. And normally when you're not eating or drinking or swallowing, that valve is nice and tight. And so you can see this valve is closed. So it's preventing stomach contents from refluxing back up into the esophagus. For a variety of reasons, in some patients, this valve just is not as functional as it should be. And we also know that there can be these kind of transient episodes where the lower esophageal valve relaxes when it shouldn't. So when you are not swallowing and it should be tight, it's actually relaxing. And you can see when it's relaxed, it's open, and that allows stomach contents to go right up into the esophagus. So this valve is actually very important in developing GERD. Okay, next is a hiatal hernia. And this is pretty common. So a lot of you may have heard of it, or you may have one. Typically, it's something that is seen on endoscopy or on an imaging study. Often that's kind of where it's left. It's often something that's not really talked about past that, but it is certainly a precursor for developing reflux. So let's talk about what it is and why it's important. Again, I'm going to focus first on the top picture. So looking at the left-hand side here, this is normal anatomy. So right here, if you can appreciate this is the diaphragm, which is the breathing muscle. And the esophagus runs right through the diaphragm and into the stomach here. And then we go into the small intestine over here. So the breathing muscle, called the diaphragm, also known as the hiatus, it goes up and down when you take a breath. You can develop a hernia there. And a hernia, simply put, is when there's a hole or a defect, and it allows a bulging, so things to kind of go through that hole or defect that creates a bulge. You may have heard, or you may know, or you may be somebody that has a hernia somewhere else. The abdomen, such as the belly button area, the groin, these are all common places to develop a hernia. But you can have a hernia with the stomach as well. And so what happens is there's a hole or a defect here at the diaphragm that allows for part of the stomach to actually slip up above the diaphragm and into the chest cavity. So, this diaphragm, not only is it our breathing muscle, but it's also separating our chest cavity, which has our rib cage, our heart, our lungs, from our abdominal cavity, which has the stomach, the intestines, the kidneys, the liver, etc. So when you have part of your stomach slipping up into the chest, that does a couple of things. One, it displaces this valve down here, and I'll talk more about that in a minute. But you can imagine, the rib cage, the heart, the lungs, there's not a lot of extra room in the chest to have the stomach. So having a hiatal hernia definitely can predispose patients to developing GERD. So looking down here at these lower pictures, take a look at the picture on the right. Again, we're getting back to that lower esophageal sphincter or valve. In this picture, the diaphragm, or that breathing muscle, is this line. It's a cartoon. So the valve is nice and tight because there's no hernia. On the picture on the right-hand side, part of the stomach has slipped up into the chest cavity above the diaphragm. And what that's doing is pushing up against that lower esophageal sphincter and basically stenting it open so that it's not working the way that it should be. And so again, you can see that valve's open. And so we have a nice highway for stomach contents to go right up into the esophagus. Now, hernias can come in all different sizes and different places too. They can be next to the esophagus. They can be right up against the esophagus. They can be small, they can be large, and that all plays a role. But these are kind of the basics here. And how do we get a hernia? Most of the time, honestly, we're not really sure. We think that genetics might play a role, frequent coughing, as well as trauma, like if somebody was in a car accident or had a chest injury, that can play a role. But most of the time it's idiopathic, which means we don't really know. Okay, so the third cause of GERD has to do with the esophagus itself. So the esophagus is basically a big muscle, and the muscles are supposed to contract in a certain way to push food or liquid down the esophagus into the stomach. And in certain patients, those muscles, they don't contract the way that they should. And so the esophagus doesn't empty as it should. So think about if you were to swallow a cup of orange juice or eat something really spicy. If normally that should go from your mouth down the esophagus and into the stomach pretty darn fast. For certain patients that have difficulty clearing whatever they're swallowing from the esophagus into the stomach, it's staying here longer. That's going to feel an awful lot like reflux, right? Or similarly, if you have reflux that's coming up into the esophagus, but then the esophagus is having a hard time clearing it back down into the stomach, it's going to stay there longer, irritating this area, causing symptoms. So the esophagus not working the way that it should can be a big factor in GERD too. All right, finally, let's talk about the stomach not working the way that it should. So similarly to the esophagus being or not contracting appropriately, sometimes the stomach doesn't work the way that it should and is very slow to empty your food. So typically when you eat, your stomach distends, of course, and it should empty most of its contents into the small intestine, so over here, by about 4 hours. So at 4 hours, at least 90% of the stomach should be empty after you eat a meal. In certain patients, they have what's called delayed stomach emptying, or a fancier way of saying that is gastroparesis. We don't always know why this happens. We do know that it sometimes has to do with the vagus nerve and nerve damage, potentially from diabetes, but there can be a lot of other things going on, and we don't fully understand always why it's happening. But if the stomach is full and it's not emptying as quickly as it should, anytime it's full, it's putting pressure on this lower esophageal valve, and it's making it much more likely that you'll have reflux of stomach contents into the esophagus. I hope that makes sense. So let's move on here. Okay, how do we find out if we have GERD? How do we test for it? Well, typically the answer would be, okay, you come into, you go to your doctor, you have symptoms of heartburn, reflux, they're pretty typical symptoms, you get put on a medication. If that medication works, boom, bada bang, you have GERD, right? Which makes sense, but we have much more concrete ways of testing for GERD that give us a lot more information. So I'm going to go through a couple of them. The first is upper endoscopy, which is probably the most well-known or most common. And upper endoscopy so the idea is similar to a colonoscopy, which most of you I'm sure are familiar with. Basically, it's a scope with a camera at the end, just like in this photo here. So while the patient is sedated or asleep, the camera scope is inserted into the mouth and down the esophagus to look at the esophagus and the stomach. We also get to look at part of the small intestine as well. What's really great about endoscopy is that we're directly visualizing that area. So not only do we get to look at the anatomy and say, okay, is there a hiatal hernia? to what's happening with that lower esophageal valve, but we get to look at the tissue itself of the actual lining of the esophagus and the stomach and see if there's inflammation, look for scar tissue, look for evidence of reflux. And we can also take biopsies. So we can take a piece of tissue and send it over to the pathologist to look at under the microscope to see if there's a level of inflammation there. We can look for H. pylori, which is a bacteria that can cause ulcers and gastritis or inflammation of the stomach. We can look for Barrett's esophagus, which again, I'll talk about in a little bit. And then, so not only is it helpful in diagnosing, but endoscopy also allows us to do therapeutics, so treatment options. For example, I talked about scar tissue in the esophagus. So when patients have a lot of reflux, the esophagus does not like that, and it builds up scar tissue. And often that scar tissue is in the form of a ring or a web. And in some patients, it feels difficult to swallow against that ring or that web. And during endoscopy, we can take a look there and see if that exists, if there is scar tissue, if there's a ring, and we can actually dilate it. We can use a gentle balloon to kind of dilate the esophagus and break up that scar tissue. So it also provides treatment relief for patients with certain symptoms. And that's just one example. We can do a lot of other things with endoscopy. Okay, so pH testing. We're talking about acid reflux. So you can imagine acid pH first is with a Bravo probe. So it's a small device that is attached to the lining of the lower esophagus that records the acid in the esophagus. So basically we place it during endoscopy and it attaches to the lining of the esophagus. And it's about the size of the tip of my pinky finger or so. And it has a pH monitor on it. So the entire time that it's in the esophagus, it's recording how much acid is coming up and hitting that probe. Typically, we do the test for about 96 hours. Bravo capsule stays there for a longer period of time. Usually by 7 days or so, it falls off and you digest it through. The other way that we look at the pH is with something called an impedance pH catheter. So this is actually a very thin, malleable catheter that's inserted into the nose, down the esophagus, and it ends at the tip of the stomach. And this actually has pH sensors all the way up and down. And we can get a little bit of different information with a pH catheter. It can tell us if the contents that are coming up or down is strongly acidic, weakly acidic, or not acidic. Whereas the Bravo probe only gives us this information right here, which is in the picture. So if you can see these red spikes, those are all acid reflux events. Unfortunately, this patient had pretty severe acid reflux. So all of these red spikes are times when the patient was refluxing and the acid was having acid reflux. In addition to looking at the pH level, we can also try to correlate patients' symptoms with acid reflux events. So the patient actually carries a pager type device. And each time that they have a symptom, so say it's heartburn or something like cough, they would press a button on that pager and the device would mark down that moment in time. And so then we would be able to go back and look at the data and say, okay, every time that John is having a cough, is he having an acid reflux event? And we can see if those two things are related at all. So it helps us to determine whether or not symptoms might be related to acid reflux. Another way that this is really useful is if a patient is having typical symptoms, so common symptoms like heartburn, reflux, regurgitation, and they're on medications for this, and they're on pretty high doses, but they're still having symptoms. What do we do? Well, we got to figure out if they're actually having acid still coming up. And so we might do one of these tests on their medications to see, are the medicines actually working, or could something else be going on? All right, moving on. So a barium swallow or a barium esophagram is similar to, it's basically an X-ray test, and we take X-ray pictures of the chest, and we're looking at the esophagus and the stomach. And we have the patient drink barium so that the pictures light up, and we can actually get a really good outline of the esophagus and the stomach. And you can see in this image here on the right side that there's actually a small hiatal hernia here. Part of the stomach has slipped up again into the chest cavity, and we can tell that on the barium swallow. So it gives us a good look at the anatomy. It can tell us if there might be a stricture or a narrowing of the esophagus. And then of course, we can actually see if the barium contrast is going back up into the esophagus from the stomach. So it gives us a lot of information about what's going on there. And we can actually also see the motility of the esophagus, so the motion of the esophagus. Again, earlier we talked about how the esophagus is like a big muscle, and it contracts to push down whatever you're swallowing. And so if there's an issue there with the motility, we can kind of pick that up on the barium swallow. So it's a good, less invasive test. Most of the testing for GERD does tend to be a little bit on the invasive side. So this is a nice study to kind of get an overall picture. Okay. All right. Last, I wanted to mention something called manometry. Now, manometry is really helpful for patients that might have symptoms such as difficulty swallowing or chest pain, a kind of a tightening in the chest, or they're not responding well to our typical medications or therapy for GERD. And basically, manometry is looking at esophageal motility. So motility means motion. And you can see in this image here that this medical professional is inserting a catheter into the nose, and then it's going to go down the esophagus, and it's going to end at the tip of the stomach. Very similar to that pH catheter that I mentioned just a moment ago. But what's different about this manometry catheter is that instead of pH sensors all the way down, it has pressure sensors. So then this patient will actually take a couple of sips of water, and they'll do some dry swallows as well. And if you can appreciate in the background here, there's this computer in this picture, and it's giving us a reading of the patient's swallows. And so we can see, we can measure the pressures in the esophagus, and we can find out if the patient has what we call dysmotility, which dys is bad, motility, motion. So bad motion, that's really all that it means. Looking for disorders of the esophagus where there might be difficulty swallowing. Again, and we talked earlier about how those can really play a role in GERD. It's also vital that we do one of these tests before we do any sort of anti-reflux surgery. And you can come back next week to learn a little bit more about that. Okay, let's move on from testing. So we'll talk about Barrett's esophagus here. All right. So Barrett's esophagus is a potential complication of GERD, typically untreated GERD. So what is it? Most of you have probably heard of it at some point, and it's basically a change in the cells that line the esophagus. So normally, the cells that line the esophagus are stratified squamous epithelial cells, and they can change to be other cells, specifically metaplastic columnar epithelium. So that's a lot of words. The way that I like to think of it is this: the esophagus is not meant to have all of this acid reflux coming up from the stomach and hitting it all the time. It does not appreciate that burning and all of that acid. It doesn't feel nice. So but the stomach, on the other hand, is very capable of handling that acid because the stomach is supposed to have acid. Acid helps our body to digest and break down food. So that's normal for the stomach. So the esophagus thinks to itself, well, I can't handle all of this acid, but the stomach can. So if I change to start to look like the cells that line the stomach, I'll be better equipped to handle all of this acid that's coming up at me. And you would think that that would be a fantastic idea. It's brilliant. It's adapting to this change of this acid reflux. But anytime that you have cells changing to be something that they're not intended to be, that sounds a lot like cancer. And that's what Barrett's esophagus is. It's a potentially, it can potentially become esophageal cancer. It's a risk factor for esophageal cancer. So Barrett's esophagus affects about 5.6% of adults. And just because a patient has Barrett's esophagus does not mean that they're going to develop esophageal cancer, but it can be a progressive disease that can change over time. And if it goes untreated, it can lead to adenocarcinoma or esophageal cancer. So of course, it's something that we take very seriously. So who gets tested for Barrett's esophagus? Anybody that's had GERD ever in their life? Well, we mentioned initially that that's 21 million people. So no, we typically test patients that have multiple risk factors for GERD. So that includes patients that are over the age 50. The male sex is more likely to develop Barrett's esophagus. Patients that have had GERD for a long time, so years and years and years. We're not talking, I intermittently have symptoms if I eat pasta, right? Patients that are of the white race or patients that have central obesity. So again, patients that carry their weight in their abdomen. We talked about smoking. So cigarette use is a risk factor, a hiatal hernia, and then of course, a family history of either Barrett's esophagus or esophageal cancer. So those are some of the patients that we want to test. And how do we test them for Barrett's esophagus? Well, we do that with an upper endoscopy. So back to our upper endoscopy, we can directly visualize that esophagus and take a look at the esophagus lining. And when patients have Barrett's, this is sometimes what we see. So obviously this tissue here looks pretty red and angry and shouldn't be like that. We call this area Barrett's tongue. And so we would typically take a biopsy of this in multiple places, and we would send it over to the lab, look at it under the microscope, and we'd be able to see kind of what level of inflammation and cellular change is going on there. And when we find out somebody has Barrett's esophagus, how do we treat it? Well, we typically start them on medications. Proton pump inhibitors or PPIs like omeprazole, Prilosec, Nexium, they're the most effective medical treatment that we have for reflux esophagitis and for Barrett's esophagus. We're going to get into medications much more next week, so I'm not going to talk about them today, but for patients that have Barrett's esophagus, they're absolutely essential as part of their treatment. And we also talked about that Barrett's esophagus is a stepwise progression, right? It can evolve over time. So for Barrett's esophagus that's a little bit more advanced, we can do procedural treatments. So that includes things like endoscopic mucosal resection and radiofrequency ablation. So mucosal resection is exactly what it sounds like. We're taking part of that mucosa or the tissue and resecting it using endoscopy. And radiofrequency ablation, we're kind of burning that tissue off to allow new tissue to heal in the esophagus. So those are two of the ways that we do treat Barrett's esophagus. And so that's just a little snippet there. I wanted to include that because, of course, it's a very important part of GERD, and it's something to be aware of. Okay, so moving on here. All right, so I'm going to hand it over now to my colleague, Sarah. We're going to talk about the treatment of GERD, and today she's going to talk about diet and lifestyle. Next week, we're going to, again, be discussing surgery and medications, and 2 of our physicians from our program are going to go over that. So come back next week and hear more about that. All right, I will mute myself, Sarah, and I'll let you take over.
All right, thanks, Alex. So for this portion, as Alex said, we're going to focus mostly on diet and lifestyle. So I liked this slide because it kind of shows stepwise how GERD should be approached. The first step should really be to take a good look at dietary changes and lifestyle changes. If those don't seem to help with symptom relief, or your GERD is advanced, then as Alex kind of primed us, then there's medications that are possible, and then there's surgical intervention or potential alternative diagnoses. And again, those will be discussed in more detail for next week. But now I'm going to talk about kind of that first step. And I want you to notice that that line intentionally goes all the way down, because even if there are medications or surgical interventions, diet and lifestyle should always be the kind of fundamental approach that stays in the background the whole time. Next slide. When I talk about diet and lifestyle, sometimes it's helpful to be a little bit clear about what that means. So for diet, I'm talking about what you eat. But then for lifestyle, which can sometimes include diet, it's really the behavioral changes. And that's really how you eat. And what I've found through the years working with patients in this population is it's as important, if not more important, to think about how you're eating behavior, than simply what you eat. But first, I want to dive into the diet portion. Next slide. What you eat in terms of triggering reflux is highly individualized. A lot of times patients come in and they have done their due diligence and looked at online blogs or portals and found kind of the standard list of dietary triggers for GERD. And one of my slides talks about that, but an example of that would be spicy foods, citrus, tomatoes, things like that. What we find, though, is that just because those are potential triggers doesn't mean that they're your specific triggers. And that's really important because it can be dangerous to globally eliminate all these foods for a long period of time without knowing if they're really your triggers. What that can lead to is nutritional deficiencies, unintentional weight loss, poor quality of life, things like that. And those are things that we want to try to avoid. So it's important to individualize, and I'll touch on that. When you are looking for foods, it's good to note that usually if you don't have symptoms within 3 hours, it's unlikely a trigger for you. So that's a good kind of rule of thumb. It's not always perfect, but it's pretty good rule of thumb. And the reason for that is, for most people, unless you have delayed gastric emptying, which Alex had talked about, then most food leaves your stomach within 3 to 4 hours. And once it's moved past, kind of down your esophagus, into your stomach, and past your stomach into your small intestine, it's unlikely to cause any of these symptoms that we're talking about. And a dietitian can be really helpful there, which is why a dietitian like myself works in the GERD clinic, because it can be kind of overwhelming to take a good detailed look at your own diet. Next slide. This is from a recent journal article on GERD in general, but specifically also the dietary implications of GERD and the relationship between the two. I like this summary slide by Newberry and Lynch because I think it showcases not only the dietary components, but also a few behavioral components that I'll touch on. What the first column are those factors. The second column is the mechanism. And as we've reviewed already, there's a couple of different ways that you can have GERD get triggered, right? It can be irritation on the mucosal lining of your esophagus. It can be because that LES is lower esophageal sphincter, or that valve that we talked about earlier. It can kind of relax that and make it a little bit more open rather than tighter. And then there can also be a lot of increase in pressure. So there are a lot of different mechanisms at play here. The key word here, though, in the title is proposed mechanisms. Dietary studies are really hard to do for a couple of reasons. One, it's hard because there can be a lot of confounders, just meaning a lot of variables that can affect the true direct causal link. And then it's also really hard to track exactly what participants in studies are eating unless, and there are studies like this, we recruit you and we put you up in a hotel or a study site and you live there for a while and the only food that you eat is what we give you. Those are really expensive. They're pretty labor intensive, so they're hard to do. So all these are proposed mechanisms based on association studies. So, causation doesn't equal correlation. It is something that I like to bring to light there, right? So just because there's a strong correlation doesn't mean that there's a strong cause. But the association studies, there are a lot of them. So that builds up the evidence base. Next slide. So these are the two where we're talking about the mucosal irritation. So these are the things that we think about where an easy way to think about it is you wouldn't want to put that food on a wound. It would sting, it would hurt. The same kind of thing with the esophageal lining where it would be irritative there. And so I just wanted to point those two out because sometimes those foods can irritate and it can feel a little bit like heartburn, but it's not actually. So that's why it's really helpful to have those battery of tests that we've talked about, because it's possible that what you're experiencing isn't true GERD either. So I just like to point that out. Next slide. I've summarized the two categories, and I like to review these with patients in our clinic because I think it helps people figure out based on their heartburn presentation. So are they having chest pain, burning, kind of what you see in the commercials? Or are you having more pressure in the lower sternum? Are you having more bloating? Are you having heartburn that lasts for the whole day, right? Those presentations are helpful when you talk with your physician about your symptoms. And also when you talk about the dietitian too, because that might help us target which foods could be contributing to your GERD. So we have the acidic or irritative foods. That's the citrus, tomatoes, right? Pretty acidic. Coffee and tea are also fairly acidic, but they also have some compounds, including the caffeine itself, that can induce reflux. Carbonation and also spicy foods. So those are some of the classic ones. The lesser known ones are the refluxogenic, what I call refluxogenic. So more likely to induce reflux either by relaxing that valve and allowing it to open. That would be the mint or the chocolate can do that. carbonation, because it takes up a lot of volume due to the CO2, that can really have that open up. I think we've lost our slides, but I'm not sure.
Yes, I think we have. I don't know. I'm sure Kim is working on it. I don't know what happened, how we would lose them. Let's give it a moment or so. Take a break here. Maybe we can take a couple of questions. Do you want to do that?
Sure. Yeah.
Just to kind of
I'm back.
make
I
use-
can put it back on if we're.
Oh, can you put it back on? Okay.
Yeah.
Yeah, if you can do that quickly, that would be great. We do have some good questions coming in, so if you
Okay. Keep on coming. Keep on coming.
Yes, exactly.
So,
Oh, thank you, Alex. Great.
Thanks, Alex. So in terms of the refluxogenic foods, so mint and chocolate are thought to relax the lower esophageal valve. And mint, you know, for people who have IBS, irritable bowel syndrome, or abdominal cramping, peppermint tea or peppermint kind of pills are pretty well established because they can they act like muscle relaxants, which is a good thing in that situation. It's a bad thing when we're talking about reflux in that lower esophageal valve. So mint is a known one. Chocolate, carbonation for the same reason, the volume. And then fatty or fried foods, so high fat content meals can trigger the activation of cholecystokinin, which is a component that they then can relax the lower esophageal valve because it thinks that you have food coming, and so it relaxes that valve. It also ends up taking longer to digest. It sits longer in your stomach. So that way it is more likely it can be there longer and therefore provides more opportunity to cause some reflux. So that's some dietary triggers that are good to think about. Again, not to globally eliminate them for a long period of time, but ones to look out for if you or a loved one is dealing with some reflux. So next slide. When you meet with a dietitian, often one of the things that they'll ask you to do is go through your diet, what we call a diet recall. But food records are another way where instead of trying to think of what you ate in the last 24 hours or yesterday, doing it in real time or as close to real time as possible. And usually we ask patients to do a 3-day food record. That's not too long that it's too cumbersome, but it tends to capture enough diet variety. And you can make your own. You can look at this recording later and kind of take a screenshot, but it's nice because if you look at the columns, right, we have the time in the left-hand column, and it's important. It doesn't need to be exact to the minute, but approximate timing. You have the food and the amount of food, and then any further descriptions. So for the dietitian to kind of look further into any ingredients that could be contributing to your reflux, and then your digestive symptoms. So in this case, it would be any sort of reflux symptom, chest burning, bloating, cough, belching, things like that. And it's good to put the time there too, because what we're looking for, as I mentioned earlier, is what time did you get that symptom and what time did you eat the food? And usually if there's more than a 3-hour gap, I discount that as a possible trigger, a direct trigger. Unless it's bloating, since bloating can also be lower down in the digestive tract in your small intestine, that would be one example of the exception to the rule. So food records are helpful. It's good to be as detailed as possible with these. And sometimes it's helpful to do this before seeing, let's say you're going to talk to your primary care provider before going to a specialized clinic like a GERD clinic. It's nice to do this before, just so that you have some objective data too, and remember what you've eaten. The next slide. Now we're moving from the dietary triggers to now behavioral ones. So I mentioned earlier, how you eat can be just as important as what you eat. So once you've kind of determined from working with a dietitian, working with food records, identifying the timing of things, and you've identified a few foods, or maybe you've noticed that there are many foods involved, and you don't feel rightfully so that you should be avoiding all of those foods, then it's good to always look into your behaviors as well. And the first two listed here are probably the most common and the most effective. So we all live busy lives. We're a society that's always on the go. We tend to eat on the go too, in between meetings, in the car, dropping off kids at soccer, whatever it might be, we're always on the go. But we're not really, our digestive tract isn't really set up for that. So you have enzymes in your saliva that help break down carbohydrates, the enzyme's called amylase. And if you chew a couple bites and quickly swallow, two things are happening. One is you're not allowing that enzyme to start breaking down at least the carbohydrates, maybe not the protein and the fats, but at least the carbohydrates. And so that means it's going to take longer to digest in your stomach. The second thing that's happening is now you have a larger bolus of food going down your esophagus. Really, what we should all be doing is chewing our food to a mashed potato or applesauce type consistency. That is often something that we aren't doing, but can be really beneficial. And this, by the way, is not just helpful for reflux, but also for lower gastrointestinal symptoms like IBS, bloating, etc. So eating slowly, chewing your food thoroughly sounds like common sense, but if you take the next couple of days and think about how fast you're eating and working to slow that down, I think you'll notice a difference. The second one is consistent meal times. Our stomach produces these gastric juices in anticipation of a meal. And just like circadian rhythm for sleep, our digestive tract also we're learning has its own circadian rhythm. And it likes to predict when you're going to eat. Are you someone that eats at 8 a.m., then noon, then 6 for dinner? Are you someone who eats sometimes at 8 a.m., sometimes you skip it and don't eat until 11, and then maybe at 2, and then a snack at 3 and 4, right? How erratic is your eating pattern? It's okay if it's not all the time, that it's consistent. There are going to be days traveling that it's inconsistent. I'm talking about 80% of the time. And a good rule of thumb is every 3 to 4 hours. So harkening back to, it takes about 3 to 4 hours for most of the food in your stomach to leave and go to your small intestine. We want there to be some emptying in your stomach, but not for too long. So we want to avoid grazing, but we also want to avoid intermittent fasting, especially in this population with reflux. We don't want to go long periods of time. The exception is sleep. It's good to have about 10 to 12 hours of fasting while you sleep. And that is really the time where your digestive tract kind of cleans itself, so to speak. The other two are other kind of non-diet behavior related factors. So tight clothing around the waist. So I'm talking about the leggings, the tights, the things that, belts that we cinch around our waist. Our society has kind of moved into that a lot as a way of kind of stressing ourselves. And the problem with that is that it puts a lot of pressure, whether you have central abdominal weight or not, excess abdominal weight or not. That tight fitting clothing puts unnecessary pressure there. And over time, there have been some associations with that and development of hiatal hernias or GERD without hiatal hernias. So something to think about too. It's the same reason why in pregnancy, a lot of times women will complain of increased heartburn. There's that pressure there, right? So any sort of pressure, tight fitting around the abdomen should be avoided. And then maintaining a healthy weight. There are a lot of studies, association studies, randomized control trials, which are really the creme de la creme of studies. And those show that if you maintain a healthy weight, your risk of developing reflux, or if you already have reflux, having it get worse, is greatly diminished. Next slide. So when talking about weight management, there's two sides to the coin. So thinking about weight loss, if you are overweight, if your BMI is greater than 25, if your BMI is within normal weight, there's no evidence to suggest working on weight loss to move your BMI points. So this is really if you're in that overweight or above category. A lot of studies have shown that 10% weight loss showed significant decrease in reflux symptoms. Reliance on PPIs here as proton pump inhibitors, an example would be like Nexium, which you see a lot in drugstores, and overall quality of life. So 10% weight loss is a common number that's thrown out in weight management studies. That amount of weight should take you at least 6 to 8 months. This should not be a rapid weight loss, because that almost always comes back and usually comes back with more. So it should be slow and steady, usually around, I like to say, 0.5 pound to 1.5 pounds a week is a good weight loss rate. Conversely, increase in weight can result in risk of developing symptoms. And so more specifically, BMI change of 3.5 points. So going from BMI of 24 to 27.5, that 3.5 point change was significantly associated with the development of reflux. So really, if you're at a healthy weight, stay there. If you're not, work safely and gradually, ideally with the help of your provider or dietitian, on coming down to closer to an ideal weight. Next slide. And it would be remiss of me not to talk a little bit about stress management. A lot of times this is not discussed, and it can sometimes pop up at a future session and can really change the game. So if you're finding that dietary management is under control and you've worked on these behavior changes, but you're still not seeing a lot of movement, and you aren't at risk in terms of surgical or needing to increase medication, then looking really into stress management is helpful. So stress is correlated with so many different diseases and disorders, and GERD is not an exception. Stress leads to a disturbance of what we call the brain-gut axis. This is kind of a hot topic now in the nutrition world. That vagus nerve that Alex had mentioned earlier on in the presentation is related to this brain-gut axis. So that's essentially the nerves and the signal from your gut to your brain that tells you kind of when you're full, and when you're hungry, and when something doesn't feel right. So there's a lot of communication there, and stress can cause changes to that and lead to the development of GERD. Next slide. And then a lot of times we have patients come in who are worried about medication use. And so all these medications and potential side effects will be talked about by the physicians at the next talk. But from a nutrition perspective, there doesn't seem to be a major concern for nutritional deficiencies when you're on these anti-reflux medications. The exception would be if you're on the kind of highest dose of these medications for a long period of time. For example, if you do have Barrett's esophagus and you're on these higher dose medications for a long period of time, it's always good to talk to your provider about potentially testing these. These 4 nutrients usually need acid in the stomach to be activated and then digested and then absorbed. So without enough acid in your stomach, there have been some studies that have shown that these nutrients can be depleted. So you might need to supplement with these. It could just be a basic multivitamin. You might need to talk about changing the medication if supplementation is not well suited for you or well tolerated. But always talk to your doctor before starting a supplement, before changing a supplement, and asking about blood work for this can be good. Okay, next slide. So that's the end of the diet talk in our talk for today. So we'll open it up to questions.
Great, thank you for that fantastic presentation. I know I learned a lot, and I'm sure others have as well. And as I said, we have many questions that have come in. So I'm looking forward to getting those started. So I will start from the top, actually. And you all, I think I'll have you all decide which person wants to answer or both. So what are the risks involved with an upper endoscopy?
Sure, I can take this. So it's a good question to discuss with your gastroenterologist or the provider that's doing it, because of course it does depend on the patient themselves. And something that we always consider whenever somebody is having any sort of procedure or surgery is that patient's specific history. So their other medical conditions really play a big role. So in general, these procedures, endoscopies, colonoscopies are very, very safe, but everything comes with risks. And most of the time they're related to the patient's specific other medical conditions.
Okay, great, thank you. How much radiation is involved with the barium swallow? Is there increased risk in a person who has had other x-rays such as radiation treatments for breast cancer?
That's a great question. I'm not sure about the specific amount of radiation, but it's similar to an X-ray study. And what I would say to that is that if this is something that has been recommended for you, anytime that we do an imaging study or we recommend an imaging study, you always want to make sure that you're going to be able to do something with the results, right? We never want to just order something just to order it. So typically it's a conversation about risk versus benefit, right? And if we feel like we're going to get benefit from this study, then maybe that outweighs the risk. About the specific amount of radiation, that's definitely something that can be answered by radiology. And I actually have called down to radiology to ask that specific question, and I can't remember what they told me, but it wasn't too significant compared to an X-ray.
Okay, all right, thank you. What about the risks of long-term use of antacids? Are there some antacids potentially riskier than others?
Sure. So I'm sure that the physicians next week will get into medications a little bit more. Antacids are things like Tums, Gaviscon, Maalox, and my thought on them is they are very safe. However, we often have patients that come in and say that they will drink a whole bottle of Maalox or Gaviscon when they have symptoms to feel better, and that is not safe. Similarly, taking an entire bottle of Tums is not recommended. So if you're following the dosing instructions on the bottle for these medications, they're over the counter, then they are very safe. But just like anything else, if you take too much of it, it can become unsafe.
Okay. And I'm actually going to follow up with same kind of topic area that you could probably just elaborate on. Is the amount of mint in flavoring Tums, other medications, and teas very unimportant if not used at bedtime?
Sarah, you want to take this?
Yeah, I'll take that. Yeah. So that's a great question. And the short answer is it is pretty unimportant. But it is helpful if you feel like it could be contributing, depending on how much you're taking at that time, to try a few days when you do take that versus trying a few days when you don't. That's really the gold standard of testing whether or not that is triggering reflux. I assume if you're taking the Tums, it's because you're having a reflux episode or a sensation of some sort of heartburn. For the teas, depending on how much mint in your tea, if it's a peppermint spearmint tea, then that close to bed could trigger reflux for reasons that I mentioned.
I'll just add to that too, because I think that I'm not sure about the Tums specifically, but some of those medications over the counter are not only marketed towards patients with reflux or GERD, but indigestion overall, which is kind of a fancy way of saying you ate too much or you ate too much of a bad thing and now you're having all sorts of symptoms, right? Not necessarily simply reflux of stomach contents. And so, Sarah had mentioned earlier that mint can help and relax part of the bowel, which can be great with lower digestive symptoms that can come on with indigestion, but might not be ideal for GERD symptoms. So I guess all of that to say, when you're picking out these medications in the drugstore, really think about what you're taking them for. And read the labels.
Great, good recommendation. If acid is aspirated at night while asleep, could that cause lung damage?
Yeah, that's a great question. And it definitely can. That's one of the concerns, with patients that have frequent nocturnal or nighttime symptoms. We recommend obviously doing what they can to reduce them. So sleeping with their torso elevated, for example, to basically offset gravity, right? At making sure that you're not eating too close to bedtime, all the things that Sarah went over. But yes, when you're having regurgitation, and sometimes that can, so basically stomach contents, right, coming up into the esophagus, potentially into the mouth, spilling over possibly into the airways. Unfortunately, that can, in some cases, lead to things like pneumonia, aspiration pneumonia. So we actually see a fair number of patients that come in with that as one of their major complaints. Yeah.
Is it possible to develop a sensitivity to some of the foods that were discussed tonight later in life? And would this indicate some physiological changes that are causing this new sensitivity?
So by sensitivity, I'm assuming that means that they then become a trigger for reflux. The answer would be yes, in terms of it, your GERD can progress. And so there can be more and more foods along the way that start to trigger your reflux. But if your reflux is well managed, it's rare for a food to randomly start to then trigger your reflux. So if that is a suspicion, what I would then suggest is then taking a look at kind of the eating behavior surrounding that food. If that food had been fine, and then now you had a recent episode where you ate that food and you had what you thought was reflux, one, to kind of Alex's earlier point, was it reflux or was it indigestion, kind of a more kind of global and general symptom, or was it because you ate too fast, too much, too late at night, laid down right after? So thinking about those behaviors too.
Great, thank you. Does spinal degeneration, as with osteoporosis, put added stress on the stomach area and thus increase GERD symptoms?
That's a good question. I'm not sure that I can come up with a direct association there. Maybe I'm not fully understanding the question. This might be a little bit off topic, but the association that I'm making is that in patients that have scoliosis, so where there's a curvature, abnormal curvature of the spine, we know that that does kind of put pressure on the hiatus or the diaphragm area, and can maybe be a reason why patients develop a hiatal hernia. And so there's a relationship there, but as far as osteoporosis, I'm not sure about that. I suppose if you're kind of losing, height in the vertebrae, there can be some shifts there, but I think we might be overreaching.
Okay. So we have a couple of specific questions, I think probably that are specific to something that folks are, individuals are dealing with, but I think they are good general information. How long is heartburn expected to last after a meal? Because a lot of times I have heartburn in the morning through noon when I haven't even had breakfast and just drank water. Plus I have a slanted bed to help while I sleep. All this being 12 hours after my last meal.
Do you want to go first, Sarah?
Yeah. So this could be related to the fact that you haven't eaten. So it might be helpful to have something in the morning to see if that helps alleviate the symptoms. And what I would start with is something that's starchy, because that's going to be more rapidly digested. So it's not going to sit there very long. It's easily digested, and it tends to not make you feel overly full. So any of those kind of concerns about added pressure or anything, and if you aren't very hungry, that can also be a little bit more palatable. So something like a piece of toast, maybe a tablespoon of peanut butter, nut butter, but really something small to start and see if that helps. It's also possible that you had nocturnal reflux and then it's just continuing for a while. I'm not sure what you thought, Alex.
Yeah, I definitely agree with that. And then I would say that, the way that people experience symptoms is very variable. So certain patients might feel things specifically after they eat, or, if they bend over after a meal, they might have regurgitation, and then it goes away. Whereas in other patients, their symptoms tend to be a little bit more constant and persistent, kind of not necessarily directly related to just having had a meal.
Great. So instead of what foods you shouldn't eat, what's a good diet for patients with acid reflux? Is dairy okay? Salads with dressing, cooked vegetables, salmon? Any suggestions?
I love that question because it's focused on what to add rather than what to take away. And that's definitely a very healthy approach. All of the foods that the participant asked about are fine. Some people anecdotally will say milk or dairy actually soothes me, and it helps. It's kind of a natural remedy to heartburn. There's not a lot of scientific evidence to back that up, But I think the cooling effect of it, it is technically a basic food. So it's not an acidic food, it's a basic food. So dairy, kind of answering, the question also in terms of, is there a kind of a natural treatment, I guess, too. Sometimes dairy can help. But in terms of food to eat, really, the sky's the limit as long as it hasn't been deemed as a personal trigger. So again, even those foods that I listed as possible triggers, you might be able to consume. It's really also then after that about how fast, how much, etc.
Great. And then can you recommend some natural treatment rather than antacids?
I mean, I think our diet and lifestyle changes are really the best natural treatments that we have. I can't speak to this from a data perspective, but I have had patients, and maybe Sarah, you can add on to this, tell me that aloe vera has helped them, but I am not aware of any concrete medical evidence to support that. So I can't recommend it.
Okay.
I would also kind of agree with that. And aloe vera, I have heard anecdotally, but I don't know of a lot of studies. Another one that I have recently learned about is sodium alginate, and that there are some studies that suggest it kind of acts as a barrier. Again, I haven't looked into it enough to professionally recommend it, but I think talking about that with your provider and asking about that, having your provider kind of look into the research, it's helpful always when you're trying some sort of natural remedy to also talk about it with your provider. So a great example is there are some supplements out there that can interact with medications, like St. John's wort is kind of the poster child for that. So you can get it. All supplements, no supplements rather, are inspected by the FDA because supplements aren't considered a food or a drug. So whether it's probiotics or herbals or things like aloe vera or sodium alginate, all these things are not well studied because they aren't always, you can't always assume that what is advertised is in it because they are inspected by the FDA. There are third-party testers out there. So I would use caution and always discuss it with your provider, just to make sure that there's no potential interaction with any other medication that you might be on.
Great.
Yeah,
Great.
I think it's like Sarah said, it's really important to understand that any sort of supplement that you're getting, no matter where you're getting it from, you really can't be sure what's actually inside it. And I think that's again, it all comes back to a risk benefit and something that should be discussed with your provider. Yeah.
Great. Okay. How do you determine what tests to do? I hear pH testing is uncomfortable.
Yeah. So, unfortunately, a lot of the tests that we have for GERD are a little bit more invasive, I guess, I would say. And it really is a case-by-case discussion. So, it's not that we immediately jump to all of these tests. We don't want to just subject people to all these catheters and endoscopies if we don't need them. Really, it depends on the patient's symptoms, their quality of life, and their response to medication. So, somebody comes in and they're, having heartburn and it's pretty intermittent, it's well controlled with medications and diet changes, and there's really not a big need to do any additional testing unless we have concern for them, something like Barrett's esophagus. So it's definitely on a case-by-case basis. And what I'll add to that is I find that for better or worse, most of our patients that do require testing or would benefit from testing tend to be suffering enough from their symptoms that they, are quite amenable to the procedures. And as uncomfortable as they sound, once the catheter is in place, it tends not to be bothersome. So
this is very specific, I think, for Sarah. Why are blueberries on the list of not to eat? I don't know if you can.
Blueberries.
Blueberries, yes.
So they're not specifically on my list, but they are on lists out there. I think where that comes from is there are a couple of well-known books out there on acid reflux and diet, and a couple of them they've done kind of laboratory tests where they test the pH of foods, ripe, unripe, etc. And I think that blueberries, I suspect, is a little bit more acidic. With that said, it's not on my list of kind of common trigger foods, but anecdotally, I have had a couple patients who find that blueberries do trigger their symptoms. And really, if you find consistent symptoms after you eat that food, then it is real for you. And so you don't need blueberries in your diet. They are an excellent source of fiber and antioxidants. So I would really make sure that you're sure before eliminating it. But yeah, I would just be careful about how long the list is of foods to try to eliminate.
Yeah, I sorry, add to this, Sarah, but I think you and I both see a lot of patients that come to us and they have done a lot of research on their own. We're lucky we live in an area where our patient population, everybody's very well educated and they do their own research, and sometimes that does not benefit them, and they come to us and they've been following a very strict diet because they see these long lists of they should be avoiding all of these food, and of course you see it, it makes sense, you're going to try it because you want to feel better, but sometimes that can impact the quality of life and weight loss and lots of other things. So that's not to go at it alone.
Great. And I don't know, you might have mentioned this a little bit, but I'm going to ask the question anyways, that's listed here. No mention of being upright versus lying down soon after a meal, which would help GERD symptoms. Any comments? How long a time post-meal do you need to be upright?
You're correct. I didn't mention that, but it is definitely one component of behavioral change. Typically, we recommend 2 to 3 hours sitting upright. Again, kind of thinking about how long it takes in general for food to leave your stomach. A good majority is gone by the 3-hour mark, even more by the 4-hour mark. Usually 4 hours is extreme. So 2 to 3 hours seems to be enough.
Okay, great. I am here. Let's see. So why do we get bloating? And if it is consistent and the stomach gets even larger and harder, what can we do about it?
Yeah, so bloating is one of the more interesting and to be frank, a little bit more complicated symptom because it could mean a lot of things. It's not specific to reflux. So just from that short description, it's always good to talk to see a gastroenterologist. It could be a number of things, and it's good to rule out anything that could be treated through antibiotic or some other means before going down the road of trialing some dietary elimination or reflux testing if maybe it's something else. And bloating, there can be secondary GERD, meaning that if you have a lot of constipation or bloating or IBS or even inflammatory bowel disease, and that you have these symptoms, that in turn can cause so much bloating and pressure that makes you have some of these reflux episodes. So really, instead of treating the GERD, you want to treat the cause of the GERD. And so it's good to get that checked out first. And gastroenterologist would be my recommendation. I don't know about what you would say, Alex.
Well said.
Should one try weaning off PPI from time to time?
It's a good question, one that we get a lot. And it's more complicated than just a yes or no answer. It really depends on your symptoms. If you are somebody that's been on that medication for years and years, and Sarah and I have done presentations back in the day when we could all be together in a room, and we would ask people, how many of you are on PPI medications, and we would go over decades, and it's surprising how many people raise their hands, and I say that because at a certain point, it's almost like one of those medicines that's on your medication list and you kind of forget why it's there. If that's the case for you, then yes, trying to come off of it and, wean down to a lower dose or a different medication definitely makes sense. On the other hand, if you are taking medication and your symptoms are not well controlled, then, probably not. You might be a good candidate for additional testing to make sure we know what's going on. But overall, we want patients to be on the lowest amount of acid suppressing medicine as possible. And for some patients, that's a proton pump inhibitor. Sometimes it's something like Nexium, like twice a day. Sometimes it's an occasional Tums. And there can be a bunch in the middle too. So it's pretty patient dependent.
I don't know if you can get into this detail or not, but we had two questions kind of specifically almost thinking of next steps. Can you recommend dietitians that specialize in the treatment of reflux? And then this kind of a second question separately. Can you recommend a gastroenterologist who is sensitive to patients with fibromyalgia? I don't know if you feel like you can give that detail or direct those two folks.
Well, I mean, if they're within the area, I'd want to come to our practice. I obviously recommend Sarah. I don't know if she has any, I don't know if you have any other contacts, Sarah, but and then in terms of a gastroenterologist, the GI doctors that we work with are great. And I think finding somebody that is a good fit for you, no matter what specialty it is important. So I would say come to our program.
All righty. And do they go through their PCP for that?
Yeah, there's a couple of ways. So their primary care doctor can submit a referral. They can also go online and just call us or even make an appointment request online. And it's on the Newton-Wellesley Hospital website.
Okay. This is kind of general, so I think we probably touched on it, but I will mention it. How do you deal with diagnosed GERD that usually doesn't cause discomfort, but is definitely causing problems, along with a hiatal hernia and another issue in that area? She forgot the name of that, and taking medication as well. So kind of a lot of things going on at once. I don't know if you can help there.
Yeah. So, I'm wondering if she means, she mentions GERD that's causing problems. I'm not sure what those problems are, but it could be esophagitis. So inflammation of the esophagus. It could be Barrett's esophagus. And in those cases where there's visual, damage or inflammation, then, taking medications, it doesn't just become about symptom control, but it becomes about kind of healing that area and preventing progression of disease. So, it's important to, again, kind of the standard answer, but, for situations like that, it's important to talk with your provider and understand and make sure you ask questions about, well, why am I taking this medication and what is it doing? And if you don't have any symptoms and there's nothing concerning, and endoscopy's been done and there's no concern for Barrett's esophagus, and then, in certain cases, it's really about symptom control and not necessarily needing medicine. So I hope that's helpful.
Great. Thank you. And this question is, I have had very few GERD symptoms for a month or two, but always have scratchiness as a sore throat. Does diet and lifestyle help sore throat or only time and pills? Any comment on that?
Yeah, so I can go first, Sarah. I think, ultimately it's a voice hoarseness or scratchy throat is one of those symptoms where, and unfortunately, it's an area here in the neck where there's a lot of things going on, right? So potentially it could be irritation from reflux from the stomach coming up. At the same time, it could be irritation from postnasal drip, so from the sinus cavities going down into the esophagus and irritating. It could be a problem with the voice box. There are a lot of factors that are at play in this region, and that's where doing additional testing or medication trials, diet and lifestyle trials can be helpful to really figure out what exactly is going on, because you don't want to just treat things without really knowing the cause.
Yeah, I would agree. And if it's deemed that it is GERD related or reflux related, and so then maybe it's more like the silent reflux, then diet and lifestyle can play a role, and similar approaches can help. Usually it's more behavioral rather than food driven, because it's hard to tell what foods are triggering your symptoms. But yeah, good to figure out what's causing that, because it might not be the GERD.
Great. Well, we are just about at time. So I was so glad that we had ample time for the presentation, as well as all these great questions, and hopefully that has really helped folks. And I do encourage people that if your question wasn't necessary, we didn't get to it, maybe hold on to it for the next series, and hopefully it'll be still relevant, which I'm sure it will be, and to ask at that point as well. But at this point, I really do want to thank Alex and Sarah and for everyone for joining tonight. As I said, I learned a lot that I didn't know before, so hopefully everyone did as well. And we will be sharing resources with those who have attended and registered for the event, as well as the recording. So you'll be able to listen to all this information again, and that will be coming out from the NWH Collaborative and will be sent out to you by the end of the week. And then I just want to remind people that Newton-Wellesley's community programming has a continuous menu of programs on a variety of different topics. And these are listed on our website, which is www.nwh.org. And we update this frequently, so we do encourage you to check back often so you can see what's being run through, and it's all virtual at this point, which is much more convenient. And please, forward and let your family and friends know as well, so they can join us. But on behalf of Newton-Wellesley Hospital, thank you so much for joining us this evening, and have a good rest of the night.